turning our attention back to dry January. Nothing's drier than reading a clinical guideline, but many of you have been hard at work reviewing clinical guidelines and identifying evidence gaps. So I want to thank all of you who have participated by posting your ideas of opportunities for our community to contribute out on the forums. For those of you who haven't paid attention, I'll paste the link in the chat, but on the forums, we've been having a robust conversation about the various different opportunities that many of you have identified. And really the motivation for this, to remind everybody, is that rather than just speculating on ideas that might be useful, the motivation here is if as a community we could identify research opportunities driven by what the guideline recognizes as an important question that we need good recommendations, but for which we don't currently have good evidence, then maybe we can be using our collective capabilities within the OHDSI community to evaluate to generate evidence that can either support a guideline or evaluate the utility of the guidelines that exist. Many of you have posted, and I invited all of those who posted to come on to this call or next week just to share their ideas. And my motivation for this is to make sure that everybody hears about these opportunities and thinks about collaboration opportunities. But very concretely, what we'd like to do is by the end of next week, we'd like to try to narrow down and prioritize the opportunities that collectively as a community we're going to drive forward to be evidence projects as part of our community. And so this week we had multiple individuals who were willing to join our call and share briefly their particular ideas. And so in no particular order, I'll just go through some of those. Chung Soo, you actually posted first on the forum, so thank you for your leadership and initiative to jump forward. And you also volunteered to join us on today's call. So you want to start by sharing your pitch for the idea that you had?
Yep, I can go first. Then before that, can I share my screen?
Yep.
I have very.
And while you're getting it up, and Michelle just asked, is it too late to post a guideline? Absolutely not. We want this to be a continuous conversation throughout the month. So you're gonna hopefully today will inspire you all to be getting excited about these opportunities, but also identifying other opportunities as well. All right, Chung Soo, over to you.
So now you can see my screen, right?
Yep, we can see your screen.
Okay, so I'm gonna talk briefly about some evidence gaps in obesity guidelines, and it would mainly focus on the comparing medication for obesity. About the obesity guidelines, there are many guidelines for managing obesity, but I picked 3 guidelines to review. And the first one is the American Heart Association, American College of Cardiology, and the Obesity Society guidelines in 2013. And the second is American Association of Clinical Endocrinologists and American College of Endocrinology guidelines in 2016. And lastly, the 2025 American Diabetes Association guideline. The AHA-ACCTOS guidelines give us quite general guidance on obesity based on critical questions. However, this is somewhat outdated now. So therefore, there is limited guidance on FDA-approved new pharmacotherapies and procedures and devices. Fortunately, ACC and AHA provide some additional guidance on obesity and overweight in their other guidelines as well, such as the primary prevention of cardiovascular disease guidelines. But yeah, they have some limitation because they are quite outdated. The 2016 AAC and AC guidelines provide quite holistic approach on managing overweight and obesity based on critical questions on diagnosis and complications and treatment. They clearly provide evidence gaps in their recommendations on treatment. So I focused on evidence gaps from this guideline in the next slide. And 2025 ADA guidelines mainly focus on diabetes, but they have a separate section on obesity and weight management for the prevention and treatment of type 2 diabetes. The the distinct point of this guidance is that they include and recommend very recent medications for obesity, like semaglutide of GLP-1RA and then tirzepatide of dual GIP and GLP-1RA. So what is evidence gaps in those? So most guidelines, especially AACE and ACE guidelines, highlight that there is very limited head-to-head study on efficacy, effectiveness, and safety of anti-obesity medications. Also, large and long-term followed literature are definitely required because most RCTs are conducted in relatively small sample with short-term periods. Further, there is lack of evidence on other related outcomes, for example, cardiovascular outcomes or psychiatric outcomes between drugs, and evidence on outcomes in underrepresented population, including older adults. The AACE guideline depict their preferred medications by clinical characteristics or coexisting disease very clearly, and we can easily see and notice where we can fill in this gap through this table. So even though we can expect challenges in conducting network studies, including limited data on prescription of anti-obesity medication due to their limited insurance coverage or limited biomarkers like weight, BMI, or race circumstance and others. However, I think providing evidence on effectiveness and safety of anti-obesity medications is quite important because it can be used as a critical reference when Obesity Society decides to prioritize medication in this new era of anti-obesity medications. So yeah, that is my pitch. I handed it to Patrick.
Yeah, no, thank you, Chung. So this is actually a great model for others to be inspired by, in addition to being a good clinical question. Maybe just one follow-up question for you, Chung Soo. So you outlined very nicely that the guidelines kind of express where there's insufficient data, and you're thinking specifically head-to-head studies. One thing maybe I missed it on that table, but could you just comment on the, you had mentioned like cardiovascular outcomes as being something that we want to pay attention to, and the type 2 diabetes guidelines, of course, like focused on management of diabetes. But what is the collective set of outcomes that you feel like we want to be able to study in terms of filling the evidence gap to support these guidelines?
I think, yeah, we need more discussion. How could we focus on specific outcomes, or we just try to approach whole available outcomes? But in my mind, maybe it is quite interesting if we also included in cardiovascular outcomes, because these days, as you know, some kind of newer anti-obesity medications are promote their benefit, including the cardiovascular outcomes. So maybe if we can include the cardiovascular outcomes if in the comparison between newer drug versus older drug, and then it would be really fantastic. So
very good. Awesome. Well, thank you, Chung Soo, for raising this. And I think it also has some nice complementary work to the work that you and the Yale team are working with Mark and the broader Legend type 2 diabetes teams. I think there's a lot of commonalities that we can build on there, which is great. So we'll keep that one in mind as an opportunity. Again, as I stated, we want to have all of these guidelines be things that we can pitch to the community, because ultimately we're going to try to narrow down and prioritize topics. And it's great to have leaders like Chung Soo that are willing to bring an idea to the table that we could potentially rally around. And I think this is a good one. In the interest of time, we'll go through a couple more today, and then we'll have another session next week to go through it. But Anna, could I ask you to, you had raised an interesting opportunity around management of pneumonia. Do you want to go next?
Yeah, absolutely. Thank you so much for the opportunity. So this question is clinical experience. In my clinical practice, we treated a lot of pneumonias in patient. Now, you would think that pneumonia has been known to the world for many, many years, and we already know how to treat it. Well, and indeed, if you look at the guidelines, you would see that all of the antibiotics are spelled out. There is a nice graphs on how to estimate risk, how to pick your drug, and they outline some of the gaps that relate to more intricate details of treatment. Like, for example, are glucocorticosteroids effective when used in combination with antibiotics? So that's an interesting question on its own. But in fact, I want to take one step back, because what I saw is that within our department of, I want to say 10 people, each of those 10 people treated patients with pneumonia without other comorbidities, otherwise perfectly healthy, differently. So one would take one drug, another would give another drug. Some would use injections, other would start with orals. So there was a high heterogeneity even within one department, let alone a hospital or many hospitals. Now, back in the days, I couldn't really do much about it. But now, when I'm in OHDSI, OHDSI is actually perfectly suited to look at how those patients are treated. So what we can do as the very first step is to just look at treatment patterns for patients with community-acquired pneumonia. And because we have many international data sources with different provenance, we are uniquely equipped to look at this problem at scale that nobody else can do. Nobody else in the world can actually characterize the treatment at scale. So I think there are more interesting questions down the line, but this very first simple question of just estimating how much heterogeneity there is would be very beneficial for the downstream analysis. And I feel that it would be a very useful paper for the community.
Very good. So Anna, so I understand the population that your target cohort that you're interested in is community-acquired pneumonia, and maybe I'll just ask a question. I don't make a presumption. Are you particularly thinking in the context of inpatient care when you were describing that, or are we talking about inpatient and outpatient, or wherever diagnosed?
I think there should be general group, and then there should be an inpatient group, because those groups are legitimately treated differently, but sometimes we are unable to estimate the intent or severity of a patient. So it may look like an outpatient, but then it quickly transitions to be inpatient. So what we should do is not split into outpatient versus inpatient, but do a general group and then do a strata of those who were hospitalized. And of course, we will need to do outcomes as drug exposures may be utilized in forms as well, because injectable and oral are really legitimately different in this case. And then, of course, if you want to make the study more complex and interesting, you can also characterize those patients both in terms of their prior comorbidities, which is important for the treatment, but also in terms of their average hospital stay and maybe some other metrics that I hope we will brainstorm all together in case people are interested in this topic.
Very good. And you're mentioning specifically pharmacotherapy as the management strategy for pneumonia, but
Correct.
are there other inpatient interventions that we would want to be able to try to include in that? Or are you specifically thinking about specifically you mentioned the question, but like glucocorticoid steroid effects?
Yeah, that could be looked at as well. But I think because which a lot of people do not realize is that when we look at combinations, it may be harder to estimate effect. So I think what we need to do first is just to look at which corticosteroids are used with which antibiotics. So that just can be another drug in this treatment pathways. And then almost all treatment is uniquely drugs. Oxygen therapy would be one that would live in procedure domain, but other than that, it's almost uniquely drugs, antibiotics, and glucocorticosteroids.
Got it. Very good. Great. Well, thank you, Anna, for raising this opportunity. And I think it's a nice complement to what we heard from Chung Soo, where there's a very clear head-to-head trials that we want to study about effectiveness. And here you're describing an opportunity for us to do characterization to summarize the heterogeneity of current care, which could help to dictate, which types of questions of effectiveness we'd even want to go look at, and to understand the magnitude of diversity in management that we may be observing around the world would be quite interesting. Thank you, Anna. And Kevin, I think you were going to go this week too.
Sure. Thanks, Patrick. So just quickly, and in line with what Anna was just talking about, I think the key focus is around the case for sort of time-varying treatment pathway analyses and the case for treatment duration presentation within treatment pathways. And so what I picked was Crohn's disease and ulcerative colitis, although this would be broadly applicable to almost any of the immunology conditions where there's a large array of heterogeneous agents that are utilized in those pathways, have sort of been changing and evolving over time as guidelines have been changing and evolving over time. So I just picked Crohn's and ulcerative colitis and just highlighted a few. So you have a very nice eye, your indication of ulcerative colitis or Crohn's disease. We have phenotypes for those, and then very much characterizing the pharmacotherapy of these and seeing how they align to current guidelines. So I don't have specific outcomes. I think some of these outcomes are actually hard to measure, and some of these things are hard to get at within some of our data infrastructure with regards to understanding the full surgical history, the Crohn's disease activity scores, and some of the other key metrics that you would need out of the data. But I think our data is ripe for characterizing these pathways and assessing how people have adopted the guidelines or not adopted the guidelines over time. These are just where the quality of evidence is either a knowledge gap or very low for ulcerative colitis, but really you could be looking across the entire spectrum of the guideline and assessing adoption of those guidelines. Similarly, with Crohn's disease, again, focusing on the adult outpatient settings, there's another broad list of recommended and non-recommended and passively recommended lines of therapy that we could monitor how they have changed over time. But there's two real key components to advance the science here. One is a more robust time-varying treatment pathways type analysis, and second, really getting in at duration of time people spend in each of those donuts, if you will, from the donut, the rings that we've done for treatment pathways.
So Kevin, these guidelines you're sharing here, these are the current guidelines for ulcerative colitis and Crohn's disease?
Right. I haven't gone back and pulled some of the older ones to see where the specific points in time would be as things have changed. But that would be of interest, right? To see how, obviously there was a time when we recommended thiopurines, and now we have guidelines that say we don't recommend them, and so it'd be interesting to sort of understand how those treatment pathways have changed over time.
Yeah, so it seems like for any specific recommendation in the guideline, we could be in a situation where either a new recommendation has been introduced or a recommendation has been revised or potentially removed, I suppose. And as the guidelines change, there's this question of adoption of guidelines and how long it takes for the clinical practice to kind of catch up with the recommendations. So that I'm clear, Kevin, you're suggesting if we were to, just as an example of what I think you were describing, like if you were to perform a treatment pathway analysis on pharmacotherapy for ulcerative colitis, you'd specifically want to look at it kind of like on a yearly basis to try to understand whether or not we are seeing shifts in the behaviors and whether those correspond to these shifts in the guideline recommendations.
Yeah, exactly. What you said.
Very good.
Many donuts over time. Also, within each of those donuts, how long people are spending in each of those categories before moving to the other pieces of therapy.
Very good. And here the interest specifically is in pharmacotherapy, which is generally well generally well captured in most of our data sources. You had mentioned something about things that the data aren't going to be capturing. I presume that that's issues associated with outcomes, associated with like remission and that kind of thing.
Right. And, disease activity scores and all of those types of things. Yes, I know I'm not going to get that. That's why I'm being a little bit vague in the outcomes, because I think similar to what Anna was talking about, some of this understanding the landscape and characterization of the pharmacotherapy utilization within these cohorts and how they align to guidelines that have changed over time is a vital gap that could be closed with our data.
Very good. Excellent. So thank you, Kevin, for sharing this. I see there's some various conversations going on in the chat as well that you can jump on here. And if before opening it up to others who want to bring it, is there anybody who's chatting in the chat or elsewhere want to comment or question any of these three presentations you've heard thus far? Andrew, please go ahead.
I wonder if these studies on guideline adherence, not all of the ones that are being proposed are about adherence. They may just be about taking some piece of evidence cited in a guideline and trying to address the evidence gap that's cited there. But where there's an interest in guideline adherence, I wonder if we want to consider as a community taking the relatively unusual step of having practitioners who are in the target population for the guideline review samples of data to see the extent to which they're able to capture the kinds of considerations that are involved in following the guideline. It's not something we typically do because it's very expensive to do, but I think the emphasis might be justified because real trust that the data are suitable from a practitioner's point of view to really characterizing the kind of things that they're looking at as they're making treatment decisions or management decisions is it's a potentially more complex task that justifies that added effort. So that's a question. I think in some other communities that would be a strategy, and I think it's worth considering here. So I don't know what people's thoughts are.
Interesting thought. Next week, I know that we have let me see the chat here. And then next week, I think we've got six volunteers who wanted to share their ideas. So I encourage you all to come and participate. For those who are interested, all of this is on the forums, and you would encourage you to post your own ideas too. But at the end of next week, what we would like to do is, after everybody's had a chance to share their idea and volunteering to lead an effort, we'll want to hear from all of you about the areas that you're particularly interested in, so we can think about how we can rally our community around focusing on some of these studies. So I guess we can give you back a couple minutes this time, and look forward to having you all engage in the conversation next week as we hear about even more of the guideline evidence gap opportunities that we can tackle as a community.